I think what we should do is maybe shift over to the shoulder, if that's all right with you, John, and I think we'll move ahead with the shoulder. Shoulder is a much different animal. I like to start with, I ask them a bunch of questions, as you would do. Can you sleep on that shoulder? What makes it hurt? How did you do this? Does getting in your shirt or jacket make it worse all of a sudden? Do you get catching or grabbing pain? Can you sleep on that side? Does it awaken you from sleep? And what qualities are the pain? Is it sharp shooting, or is it dull aching through the middle of the shoulder, both front to back or back to front? And of course, many times they may or may not have some imaging studies, but you look at the range of motion, you'll check the usual near sign for rotator cuff, Napoleon sign, push off for labral insufficiencies or tears, and you'll notice how they winch or hike their shoulder up. So if they're doing the range of motion and they're going like this, then you know that the shoulder of the glenohumeral joint doesn't want to roll, doesn't want to move. If they have full range of motion and they just go up, no problem, and it's the same as the other side, could have a few trigger points with the muscle overuse, but then you probably don't have a severe rotator cuff problem. Of course, after that, it goes to the clinical exam and the palpation. You'll look at the infraspinatus, teres major, teres minor. You look at the posterior deltoid, middle deltoid, which is a total unsung hero. I have people who have pain left, and they just, doc, it just hurts right here when I lift up. And darn if you don't push right there, and they got a real tight band in their middle deltoid, and a little trigger point with some tromial will help that. Anteriorly, of course, you have the coracobrachial ligaments, coracoclavicular ligaments, the coracobrachialis tendon, anterior deltoid and biceps, tendon sheath. Of course, anterior deltoid, again, is not everything is tendon or joint, right? There's a lot of periarticular trigger points that you can do, or injections you can do to help people with their pain. So again, we'll start with simple stuff. If you have a frozen shoulder, that really comes down to nerve blocks. In my experience, if you have an acute adhesive capsulitis where they're in god-awful pain, you're going to have to think about either nerve blocks or an intra-articular corticosteroid injection, because I really haven't had as much luck with the homeopathic injections or the multi-dose medicines. If you find tenderness in any one of those areas mentioned, you'll start in with, I guess we haven't talked about what we use. If you're new to this and you're worried about a stronger reaction, or you have a very delicate flower like I have a lot of in my practice, you will use something like lymphomyosat or tromial initially. In the muscles, you might use a combination of spaz-capriol and tromial, along with some lidocaine to make sure you got it in the right place. Zeal is more for arthritis, or in combination and transition from tromial to zeal for someone with an arthritic condition, especially in the spine. Those are my big three or big four, but if you have someone who's a very delicate flower, and you all know who they are, you probably start with lymphomyosat. That's very gentle, and it works. There was a period of time when I was doing all my athlete work with a combination of lymphomyosat and tromial, or sometimes even just lymphomyosat. It works fabulously well in acute conditions for getting that area kind of drained and prepped to heal. Getting back to each of the individual locations, trigger points in those muscles mentioned. You'll often see a muscle twitch or jump sign, and you can see the result. They'll feel it. I would prepare them for, if you haven't done trigger point injections before, you can just prepare them for that. They will feel a jump, and it will scare them because they've never felt anything like that before. I guarantee you that. Second thing would be they're going to have some post-injection soreness, and you just tell them that ahead of time. When you see a big muscle twitch, I tell them, and most of the athletes get it, second day lift, right? Second day soreness after a lift, that kind of deep soreness, is probably what you'll feel for a couple of days. And I tell them to prepare for that. What they don't want to do is go home and get surprised. They don't want to go home and feel worse that night, because they will. As soon as the anesthetic wears off, they will feel worse. Other things you can do is block the suprascapular nerve. just under the spine of the scapula laterally. You feel a little dimple there. Frequently that can give a lot of relief for the kind of the all over problem, or even the arthritic joint that has recently flared up. Of course, it is approved for intra-articular use, and you can feel free to use the tromial in the shoulder, intra-articularly, as well as a tromial-zeal combination, which I use frequently for an very arthritic joint. I don't use that initially. I'll see what we get with maybe an acute rotator cuff tendonitis with an intra-articular injection of tromial, but almost always I'll start periarticularly first, because a lot of times you can get a lot of relief from them. You do an intra-articular injection and don't get a lot of relief, it's because those pain generators are still there. Next, you would look at the teres minor, the weak sister of the rotator cuff, in my opinion. Frequently just putting a good dollop there and into the posterior deltoid, which I find, I take care of a lot of people who are chained to cubicles. They're DC, they live in the District of Columbia, work in the District of Columbia. We're a bedroom community for that. So they drive for an hour and a half. They work 8 to 10 hours and then drive home. So the arms extended forward or using the mouse all day will really aggravate some of those muscles. Coraculoclavicular joint, I've used that on a number of grade 1 and 2 sprains. You want to get those ligaments both at the joint itself, the clavicle, and then down over the coracoid. Coracoid stay safe if you stay above the tip of the coracoid, not medial or lateral to that. Also, over the biceps, you'll feel a brisk taut band over the anterior deltoid, and certainly you could be in the biceps tendon sheath if you have a positive Yergesen sign when you test for that. And just put a dollop, go right down through the muscle. You feel the muscle twitch most of the time, and give it a good 3-4 cc's of the combination of lidocaine and tromial, depending on what you're treating. Not infrequently, shoulder pain can be associated with other problems such as the musculocutaneous nerve, if they have neuropathic type pain, or the supraclavicular nerve, a group of nerves that come out over the clavicle, travel down over the calf of the shoulder and then down just below the deltoid. As you know, the deltoid is innervated by the axillary nerve that you can access posteriorly in a little divot. You can feel it, an empty space in most relatively athletic people that will access both those nerves and give that a little relief if you have a lot of referred pain down the arm. If you don't, then just stay with the muscles and the other soft tissues around the shoulder. Don't forget that the neck and the shoulder are often very closely aligned, and it's very difficult to sort out whether the pain is coming from either or both, which frequently is the case. You have to work in the upper trap, and certainly a radiculopathy you're not going to miss, but chronic overuse of the neck with postural muscle dysfunction will frequently be associated with that. Of course, you did a range of motion and a neurologic exam for the neck, and Sperling's maneuver, where you turn the head to this affected side and extend it, which narrows the nerve foramen, will almost always give you a positive referred pain down the limb at the time of study, and that will tip at the time of your evaluation. That's a pretty good sign they got some radicular pain. Again, what you'll do after injection is immediately test the range of motion, see how they feel. If it goes straight up afterwards when they only had 90 or 100 degrees, or they had that transitional pain between 90 and 100, then you know you got in the right place. If you're a lot more patient than me, you might do one injection and then do the range of motion and see really who the pain generator is. But most of the time I'll just try to do the whole shoot match that shows up as being exquisitely tender, because people are thrilled to know that you actually examine them and put your finger on that tender spot and are trying to get it away. And in fact, that's one of the things they're trying to get relief for it. And that's one of the things I talked to them. I said, when we do this, I'm trying to make a distinction that if I could put my finger, there's a pretty good chance I can relieve. They seem relieved with that.
We just lost that part of it, putting your finger on it.
So when you, getting back, I think we just lagged a little bit. When we get back to speaking with your patient and you say, wow, you have some real bad tender points here, it makes sense to them if you say, yes, I think if I can put my finger on it, I might be able to help you with some pain relief. And I know we talked a lot about trigger point injections, but that really does make a big difference. They do. There is a lot of pain generated by myofascial pain, myofascial trigger points, and it's not just about intra-articular use or lateral epicondylitis or isolated tendonitis. There's a lot of myofascial pain that goes along with a lot of these pain syndromes, particularly in the shoulder and the back. Now, getting down Lyme, if I do 2 or 3 periarticular sessions and I am absolutely getting nowhere, I'll certainly do an MR if therapy has failed, periarticular injections have failed, and I'll do an MRI. Now, I would tell you that if you do an injection anywhere near an MRI within about a week or so, you're going to generate some artifact. Probably not as much as corticosteroid injection or a post-injection inflammatory response of that nature. But just know that you did that because you're going to get some aberrant responses from the radiologist. Lastly, horizontal adduction is a great test for the AC compression test. You can push down. The AC joint is readily accessible superiorly. Don't forget about the ligaments anteriorly, and an intra-articular injection there with about 2 cc's, 2.5 cc's if you're lucky. Could be very helpful at relieving their pain. Anesthetic phase, you retest them with the AC compression test, push down, and they don't have any pain, and they're thrilled with that. I think that would about wrap up my considerations with this.